Thanks for joining us for Grand Rounds this morning. Topic of today's discussion will be what diabetes can teach us about abdominal aortic aneurysm disease, and this is an image of a large and threatening abdominal aortic aneurysm. So abdominal aortic aneurysm disease is a common and lethal condition of older Americans, and it's manifests primarily by gradual weakening and enlargement of the infrarenal aorta, which can ultimately lead to rupture and sudden death. Open surgical repair of this condition was first attempted successfully in the 1950s. And by 1965, Emmerich Szilagyi presented the American Surgical his landmark paper, Contribution of Abdominal Aortic Aneurysmectomy to the Prolongation of Life, demonstrating that for the first time, and really a landmark accomplishment, that surgical intervention could significantly extend life expectancy and prevent premature death. Today, the majority of these aneurysms are repaired by endovascular techniques. The original two FDA-approved devices in the United States were developed and commercialized by competing teams of Stanford faculty. And we continue to have significant leadership in this area, as emphasized by this promotional image on the right side, showing that these innovations, combined with other improvements that we've introduced into practice, have dramatically shortened hospital stay, significantly improved operative mortality, and expedited return to pre-existing living conditions. We continue to be leaders in the management of abdominal aortic aneurysm disease, both across the state and around the world. There's probably no condition in vascular disease that so exemplifies the comprehensive vascular care that vascular surgeons and their partners in vascular medicine provide for patients with vascular disease is management of the abdominal aortic aneurysm in terms of screening, surveillance, medical management, surgical management, technical innovations to improve outcomes, limitations of technical limitations that highlight further improvement opportunities, cost effectiveness, sustainability, both in fee-for-service economic situations as well as population healthcare systems. Vascular surgeons have defined the disease and the management of the disease now for more than 70 years. And this is represented by the branding hashtag of our specialty. Surgery is just part of our story. So we've learned quite a bit about who gets abdominal aortic aneurysms and why. This is a project that we worked on, Phil Zhao and I worked on with Mike Snyder a few years ago, using a combination of a GWAS evaluation of a large cohort of patients with abdominal aortic aneurysm disease compared to age and risk factor matched image negative controls. We could predict in an agnostic fashion which patients would have abdominal aortic aneurysm disease. It's true that the risk for abdominal aortic aneurysm disease includes both genetic and environmental components. Of the environmental risks, cigarette smoking is by far the most significant. Approximately 90% of 90% of patients with aortic aneurysms have smoked cigarettes in the past. Risk for aortic aneurysm disease in smokers is high. And in fact, it's twice as common as coronary disease, 3 times as common as stroke. In fact, cigarette smoking is closest disease association to abdominal aortic aneurysms, with the exception of lung cancer. So interestingly, when we combine the risk that's identified through genetic screening studies, in addition to the risk that's identified through electronic health records and to a machine learning algorithm, we can optimally predict which patients will or will not have abdominal aortic aneurysm disease. And so this exemplifies the combination of risks that's related to both inherited and acquired risk factors. So despite knowing quite a bit about who gets aortic aneurysms and why, and as well understanding the characteristic pathologic features of abdominal aortic aneurysm disease, including elastin degradation, smooth muscle depletion, transmural inflammation, and mural neoangiogenesis, current or prior attempts at identifying potential medical therapies that could inhibit progression of abdominal aortic aneurysm disease or prevent premature death from rupture have been frustratingly ineffective. These include interventions targeted at modulating immune activation, dyslipidemia, hypertension, extracellular structure and signaling, vascular smooth muscle dysfunction, oxidative stress, mural angiogenesis, and luminal thrombus accumulation. Clinical trials targeted on all these potential mechanisms have failed to demonstrate effectiveness in preventing progression of abdominal aortic aneurysm disease. Just the latest example of this was a study published in JAMA in May, showing the prospective randomized trial of doxycycline with the mechanistic intent of preventing MMP activity and muroproteolysis as a way of preventing aneurysm progression was found to be profoundly ineffective. Approximately 250 patients randomized to either doxycycline or placebo. There's absolutely no difference in the rate of enlargement between those groups over 2 years. Interestingly, despite the fact that these attempts at medical intervention have not proven successful, the actual prevalence and mortality of abdominal aortic aneurysm disease in the United States has actually been in decline. So this was an interesting observation by the late Frank Laderly. It was published in Circulation in 2011. Shows the prevalence of aortic aneurysm disease rising in concordance with per capita cigarette smoking in the United States in the decades after World War II, peaking in the 1980s when I was a surgical resident, and has been declining along with per capita cigarette consumption since that time. It's also true, however, that there's other changes in our society which may also impact the prevalence and lethality of abdominal aortic aneurysm disease. And probably the most interesting of these is the global epidemic of type 2 diabetes. The relationship between, the inverse relationship between rising prevalence of diabetes and declining prevalence of aortic aneurysm disease was first recognized by Frank Laderly and collaborators in the U.S. Department of Veterans Affairs Aneurysm Detection and Management Trial in 1997, where after screening abdominal aortic aneurysm patients and looking at demographic risk factors and their relationships, they were the first to identify a signal of reduced aneurysm risk in patients with type 2 diabetes. This finding has subsequently been validated around the world in numerous different ethnic and geographic regions, ethnic populations in geographic regions, summarized most recently by a meta-analysis by the Alice Cardiovascular Research Group in Tokyo, is showing that patients with diabetes are less likely to have abdominal aortic aneurysms. Aneurysms are likely to progress less rapidly in diabetics, and that diabetics are less likely to die of aneurysm rupture, a finding that the Alice Cardiovascular Research Group found curiouser and curiouser. It's also true that after endovascular abdominal aortic aneurysm repair, diabetics are less likely to require secondary intervention. The example shown on the screen here, this is a type 1B endoleak at the distal fixation point, 7 years after this patient has undergone endografting repair. And this typically occurs either because the device migrates or pulls out of this distal insertion point, or progressive aneurysmal degeneration of the common iliac artery causes it to leak around that area. And this group at Mount Sinai in New York and their large practice found that diabetics were less likely to require secondary interventions to prevent this type of problem from developing after the initial repair. So this finding is considered paradoxical in that diabetes actually accelerates risk for every other cardiovascular disease endpoint, while at the same time seemingly reducing risk for abdominal aortic aneurysm disease presence, progression, and mortality. And interestingly, this is not due just to increased risk for premature death due to diabetes. And there are other conditions, not just aortic aneurysm disease, where there is a seemingly unusual relationship between diabetes and disease outcome. This example is in sepsis associated with pneumonia. Patients with type 2 diabetes actually frequently have a better outcome than non-diabetic patients, and this is in marked contradistinction to patients with type 1 diabetes, whose outcomes typically far worse. And this may be due to increased production of the adipokine leptin, which we'll talk about more in a minute. So what can diabetes teach us about abdominal aortic aneurysm disease? Getting to the point of the presentation. There are possible consequences of both hyperglycemia itself, including effects on the extracellular matrix and the wall of the abdominal aorta, modifications to the adipokine profile, which may change the general inflammatory tone systemically, influences on immunologic tone, and potential suppression of mural angiogenesis. These are all potential consequences directly related to hyperglycemia present in diabetes. It's also possible that medications used to treat diabetes, most prominently metformin, the world's most commonly prescribed drug for type 2 diabetes, may also have a inhibitory role on progression of abdominal aortic aneurysm disease. So the idea that hyperglycemia limits abdominal aortic aneurysms, our group was the first to recreate the finding of the US ADAM trial in an experimental model. This is a murine model where aneurysms are created in the abdominal aorta by infusion of porcine pancreatic elastase for just 5 minutes. This is done through a PE10 catheter that's inserted at the aortic bifurcation. The porcine pancreatic elastase is infused, and then it strains. Then it's drained. Aortic control is released after the arteriotomy is closed. Within 24 hours by radioimmunoassay, there's no evidence of any exogenous elastase, but beginning about 3 days after the infusion of the porcine pancreatic elastase, a inflammatory and proteolytic process starts within the wall of the abdominal aorta, which leads to progressive enlargement, and larger rodents can lead to rupture and death. And this is one of basically 2 or 3 most commonly used translational models to study mechanisms of abdominal aortic aneurysm disease, and we've been using this in our laboratory for a couple of decades. And both Monica Dua of Stanford fame, as well as Noriyuki Miyama, were involved in these experiments showing that if we created abdominal aortic aneurysms in diabetic mice, we could rescue the aneurysm phenotype by treatment with insulin controlling hyperglycemia. In other words, diabetic mice aneurysms grew to be less large, but if we controlled the diabetes with insulin therapy, we could restore the aneurysm phenotype over the course of 14 days. So advanced glycation end products are a consequence of type 2 diabetes, which are deposited throughout the body in diabetic patients. And as we know, there's a biologic process of collagen cross-linking that's mediated by lysyl oxidase. This is an example of normal collagen cross-linking mediated by lysyl oxidase. There's excessive collagen cross-linking in the presence of diabetes, and there are conditions such as keratoconus in ophthalmology where there's inadequate collagen cross-linking, which can lead to disease as well. A group in the Netherlands, for example, demonstrated that patients who had abdominal aortic aneurysm disease who were diabetic had far more of the AGE pentosidine present in the aortic tissue than non-diabetic patients, which is not particularly surprising, but that aneurysm diameter was inversely related in their practice to the amount of pentosidine present. So our group used Aminoguanidine, which can prevent deposition, formation, and deposition of advanced glycation end products in a similar experimental format using mice. We showed, for example, that after porcine pancreatic elastase infusion, aneurysms were initiated and enlarged. This is reduced in diabetic mice. And again, we could rescue the aneurysm phenotype by treating these mice with Aminoguanidine, suggesting that the deposition of these advanced glycation end products was at least in part due to or responsible for the suppression of aneurysm progression seen in these models. This work was done by Xiaoyu Zheng in my lab, along with Yankee Li and Taka Shoji, under the direction of our senior research scientist and colleague, Bahui Shu, MD. And this is when Peter Glavitsky was visiting us here a couple of years ago, and he gave surgical grand rounds. So this leads to the consideration of matrix stabilization as a possible therapeutic intervention for early abdominal aortic aneurysm disease. Screening identifies primarily small aortic aneurysms. The average diameter identified at screening is approximately 3 centimeters. Screening for abdominal aortic aneurysms was actually championed by vascular surgeons in the Society for Vascular Surgery, and it convinced CMS to add a screening benefit for older men and women at risk for aortic aneurysm disease. And it remains the only cardiovascular screening disease methodology that's reimbursed by CMS because aortic aneurysm screening has been shown to reduce the risk of premature death by over 40%. So if we consider matrix stabilization as potential therapy, again, we have physiologic cross-linking by lysyl oxidase. We have pathologic cross-linking that's mediated by advanced glycation end products. We have light-activated cross-linking mechanisms, which are currently used to treat diseases like keratoconus and ophthalmologic conditions. And we're working with a company called Elucent Biomedical to use one of their proprietary compounds in a murine model to see if we can stabilize aneurysm progression by enhancing this collagen cross-linking. This work is being performed by Toru Ikezoe currently in my laboratory. So what can diabetes teach us about aortic aneurysm disease beyond matrix stabilization? Well, it's also true that there's characteristic changes in the adipokine profile in type 2 diabetics versus non-diabetics. There's an increased amount of circulating leptin. In the atherosclerosis and communities study, which was sponsored by the National Institutes of Health, which followed individuals in 4 communities across the United States for over 30 years, nearly 15,000 individuals, to look at the onset of atherosclerosis and what those risk factors were. We could see that our atherosclerotic disease equivalents, including abdominal aortic aneurysm disease. We can see that there's an inverse relationship between the development of abdominal aortic aneurysms in diabetic patients. This did not seem to be related at all to the amount of fasting insulin levels, but was in fact also inversely correlated with concentration of leptin that was identified in these individuals. And this remained true even when adjusted for other known risk factors for aortic aneurysm disease. Around the same time as this paper was published by these investigators in Annals of Epidemiology, and a translational research group was showing that in a different experimental model where aortic aneurysms are induced in hyperlipidemic mice by infusion of exogenous angiotensin II, that the addition of leptin to this model would increase expression and production of TGF-1 beta, which is thought to stabilize aneurysm disease by enhancing aortic wall fibrosis. And in fact, these leptin supplemented mice would be protected against aneurysm progression. Immunologic influences, circulating IL-4 is increased in the setting of diabetes. This is true both in obese patients as well as diabetic patients. Leptin expression is linearly related to hemoglobin A1C as well as abdominal circumference. IL-4 is important in the transition of Th1 to Th2 immunologic tone, which also can enhance the transition of classically activated macrophages to alternatively activated macrophages, which are considered to be relatively anti-inflammatory. And in this experiment, we used both a loss and gain of function approach to show that if we knocked out the IL-4 receptor and genetically modified mice, we could enhance progression of aortic aneurysms. By supplementing IL-4, we could reduce progression of aortic aneurysms. This is independent of serum glucose levels. And if we catalyze transition to M2 macrophages ex vivo and then infuse those macrophages back into the mouse, we could also suppress progression of abdominal aortic aneurysms. This work was done by Naoki Fujimura when he was working in my laboratory and presented at Vascular Discovery, the ATVB, American Heart Association Vascular Biology Conference in 2019. It's also interesting that diabetic patients are less likely to develop allergies over time. You can see the cumulative incidence of asthma over 8 years after the diagnosis of diabetes is less in diabetics than non-diabetic patients. And Gu-Ping Shi and Peter Libby at Harvard have shown, for example, that allergic lung inflammation aggravates angiotensin II induced experimental aortic aneurysms in mice. and that deficiency of immunoglobulin E protects mice from aneurysm progression. Both of these findings suggesting that this raising the allergic threshold may also reduce the prevalence and progression of abdominal aortic aneurysms in diabetic patients. Finally, mural angiogenesis is a characteristic histopathologic feature of abdominal aortic aneurysm disease. It can destabilize the wall by creating all these capillaries within the aortic wall, but it can also be a point of ingress of inflammatory cells to accelerate disease progression. Jia Guo, when she was working in our laboratory a couple years ago, also presented to Vascular Discovery Conference, Vascular Biology, ATVB, in 2019. We've previously shown, for example, that hypoxia-inducing factor 1, which is major pro-angiogenic factor expressed in the setting of hypoxia, could potentially be considered a master regulator of abdominal aortic aneurysm disease progression, and that pharmacological inhibition of prolyl hydroxylase, which can increase expression activity, actually just activity of HIF-1 alpha, is associated with, again, rescuing aneurysm phenotype after showing suppression in diabetic patients. And this is manifest by characteristic histologic changes such as increased macrophage infiltration, CD4 and CD8 T cell infiltration, B cell infiltration, elastin degradation, and smooth muscle cell depletion, all again characteristic histopathologic features of abdominal aortic aneurysm disease. So beyond the direct effects of hyperglycemia itself, it's also possible that the drugs used to treat abdominal aortic aneurysm disease may also, diabetes may also influence the progression of abdominal aortic aneurysm disease. Our group was the first to consider the possibility that metformin, which, as I mentioned, is the world's most commonly prescribed drug for type 2 diabetes, may in fact inhibit progression of abdominal aortic aneurysm disease. Actually, Bahui Shu in our group was first to actually make this suggestion. And that's not terribly surprising because metformin turns out to be have an interesting effect on a whole range of conditions, including cancer, as well as cardiovascular disease and a number of wound healing problems. It seems to have a broad influence on a number of important hemostatic and biologic metabolic pathways. In this particular experiment, we studied from the STRIDE database at Stanford that had at the time included about 2 million patients with 9 million patient visits. We simply looked by logistic regression at the relationship between metformin prescription in diabetics and the progression of abdominal aortic aneurysm disease is defined by abdominal imaging studies separated by at least 6 months. We also performed at the same time a translational research project with euglycemic mice looking to see if metformin therapy could prevent the progression of experimental aneurysms in that model. And so in this study construct, we looked at these particular aneurysm risk factors, comorbidities, and 11 separate classes of medications. And we found that prescription for metformin was the most predictive of a reduced rate of abdominal aortic aneurysm progression in this Stanford patient cohort. And the concurrent translational project that we performed in the porcine pancreatic elastase mouse aortic aneurysm model, we identified that metformin was effective at preventing progression of aortic aneurysms, even in non-diabetic mice, both the progression once aneurysms were formed, as well as the prevalence of aneurysms after the PPE infusion, suggesting that these could, and then we also looked at histologic outcomes, which are not included on this slide, to suggest some mechanisms by which metformin may be preventing aneurysm progression. Again, this work was performed by Naoki Fujimura when he was working in my laboratory. So based on histology, we can see that metformin-treated mice had preservation of their elastin lamina. They had reduced transcellular mononuclear cell infiltration and inflammation, and there's a significant reduction in mural angiogenesis. Again, all characteristic histopathologic features of abdominal aortic aneurysm disease. So this finding has subsequently been confirmed in multiple studies around the world. John Golledge and his group in Australia looked at 3 separate cohorts of aortic aneurysm patients in different parts of the country, just compared the diabetic to the non-diabetic patients, and showed that the patients with diabetes had significantly reduced rates of enlargement compared to the mean. And again, this was true when corrected for other known risk factors for abdominal aortic aneurysm progression. The Taiwanese National Healthcare System, they identified that using a nested case control analysis methodology that diabetic patients were taking metformin were less likely to have abdominal aortic aneurysms, and this was not a class effect, not true for all oral hypoglycemic agents, but true for metformin. So subsequent to that, we decided to confirm this finding in a larger cohort of patients. This work was done by Nate Itoga, one of our integrated vascular surgery residents who graduated last year, along with Kara Rothenberg, who at the time was from UC East Bay, working with the Aspire group as her professional development activity, and has subsequently completed a vascular fellowship, now works as a vascular surgeon, I think, in Oakland, as well as the Aspire group as part of the Department of Surgery. In this particular analysis, we used a Veterans Information and Computing Infrastructure Database query, or VINCI database query. Over the course of 10 years, we identified 274,000 veteran patients with abdominal aortic aneurysm disease, of which approximately 13,000 had 2 or more imaging studies separated by at least 6 months and had the onset of diabetes prior to their development or diagnosis of abdominal aortic aneurysm. And of this cohort of 13,000 patients, we identified a subset of patients with smaller aneurysms who would potentially be eligible for a clinical trial to prevent the progression of aortic aneurysm disease with medical therapy. This is the cohort that was identified in this study. You can see the age, the significant male representation characteristic of a VA study, starting aneurysm size, other demographic risk factors. Approximately 40% of the cohort was taking metformin, and we simply compared the rate of aneurysm enlargement over the 10-year time period, and those patients taking metformin versus those that were not. And on average, patients were followed for at least 4 years and had on average 4 imaging studies during that time to look at aortic aneurysm diameter. And we found a highly statistically significant 20% reduction in the rate of enlargement in patients taking metformin for their diabetes versus diabetic patients not taking metformin. So you can see the average rate of growth in the not metformin cohort is approximately 1.5 millimeters per year. The metformin cohort is approximately 1.2 millimeters per year. And interestingly, this entire cohort, all of whom had diabetes, the average rate of aneurysm enlargement was less than half that reported in the UK small aneurysm trial, which was a natural history study that was completed about 20 years ago. And in that situation, less than 5% of those patients were diabetic, again, emphasizing the role that diabetes itself plays in aortic aneurysm disease pathogenesis and progression. And this was Dr. Itoga presenting this at our National Meeting Society for Vascular Surgery meeting in 2018. So significant factors predicting reduced rate of abdominal aortic aneurysm progression were prescription for metformin, ARB, diabetes with complications, which could be a surrogate for severity of diabetes, sulfonylureas, another oral hypoglycemic, although the effect size was much less than that noted for metformin. On the flip side, predictors of increased aneurysm expression in this group, and they were analyzed by 2 methods. One is multivariate linear regression. The other was a mixed effects modeling method, and both showed very similar results. On the other hand, presence of COPD, which could be a surrogate for intensity of cigarette smoking, renal disease, active smoking status, metastatic solid tumor, again, potentially a surrogate for smoking intensity, and baseline aortic diameter are all associated with increased rates of aortic aneurysm progression. So just to summarize the findings of this really landmark observation by Dr. Itoga, the rate of enlargement in the population at large for aneurysms in this size range is approximately 2.3 millimeters per year, with the threshold for surgical repair being 5.5 centimeters, and definition of aortic aneurysm, 95%, 2 standard deviations beyond the mean in the population at large is approximately 3 centimeters. So we're talking about aneurysms between a 3 and 5.5 centimeter diameter range. Average rate of enlargement in that group is approximately 2.3 millimeters per year. The rate for diabetic patients not taking metformin is 1.4 millimeters per year. The rate in patients taking metformin is approximately a millimeter per year. So the question to be answered, to Dr. Hahn's reference, is would metformin reduce the rate of enlargement in non-diabetic patients? And if so, by how much? And if that were the case, then would metformin be the first ever medication be identified to prevent progression of abdominal aortic aneurysm disease, including potentially premature death from rupture? So what are the potential mechanisms of metformin that could potentially explain this finding? And that's the full consideration of these are beyond the scope of this presentation, but metformin is being considered, for example, an adjunct regimen or protocols for treatment of cancer. In fact, if you look on clinicaltrials.gov, there's over 200 clinical trials currently using metformin to try to enhance the anti-oncologic activity of known chemotherapeutic agents, as well as a standalone cancer inhibitor. There are indirect effects associated with metformin, such as reduced body weight, reduced inflammation, reduced insulin resistance, and glucose levels. There's a majority, or the canonical pathway of metformin activity is through AMP kinase, which can have a significant reduction on known pro-inflammatory mediators such as NF-kappa B or IL-6. It's also true that some mechanisms metformin work through non-AMP kinase mediated pathways, such as reduction in HIF-1 alpha, which could affect mural neoangiogenesis, as we previously discussed, as well as other consequences of inhibition of the mTOR pathway. It's a broad range of potential therapeutic benefits associated with metformin therapy that go far beyond the simple control of serum glucose levels. So we recently were fortunate in receiving funding from the National Institutes of Health for a R61, R33 clinical trial, the R01 clinical trial grant, which will allow us to randomize 480 patients, 240 to metformin versus 240 placebo, and then follow their progression for 2 years using CT angiography at baseline in 2 years to see if therapy with metformin will reduce the rate of progression of known small abdominal aortic aneurysms in non-diabetic patients. And again, we think this is accumulation of at least 5 or 6 years of work from ourselves, as well as numerous other colleagues around the world. I should say there's already a small metformin trial running in Austria called the MET AAA trial, which we helped get started and shared some of our study protocol with them. There's a trial running in Sweden using metformin to prevent progression of small aortic aneurysms. And our friend John Gollage in Australia is also conducting a trial there. But this trial will be by far the largest, currently being run worldwide, and involves by far the most diverse group of patients, and hopefully will give us definitive answer on whether metformin is effective or not in this application. So this trial funding mechanism, R61, R33, doesn't really allow for any significant mechanistic analysis. We'll be saving plasma and Buffy-coat, and we can put an ancillary R01 later to look at some differences between responders, non-responders, if we can find those, et cetera. But at least in the beginning, it's simply a go, no-go decision based on the results of the clinical trial. However, because we're using CT angiography as our endpoint determinant, we can look, for example, at the density or volume of peri-aortic fat. The retroperitoneal adipose tissue is now known to be a paracrine organ that can influence the progression of aortic aneurysm disease. This group in the Netherlands demonstrated there's a difference in peri-aortic adipose density at the area of maximal diameter of the aneurysm versus the uninvolved surgical neck. And at the same time, this group in the United States did whole genome sequencing on some of this fat and then noticed an enhanced signal for both innate and acquired immunity, as well as inflammation, proteolysis, et cetera, that's consistent in this area of enhanced density in this peri-aortic fat, different from other fat stores such as the omentum, et cetera. And so with our trial, we can look, for example, at the volume or density of peri-aortic fat as one particular potential mechanism by which metformin may suppress aneurysm progression. So in conclusion, There are multiple potential candidate mechanisms of diabetes-mediated abdominal aortic aneurysm suppression. Some are related to the presence of hyperglycemia. Some may be due to the unintended consequences of drug regimens to treat aortic aneurysms, such as that represented by metformin. There are novel translational opportunities suggested from some of the results of some of this research. As I mentioned, we've been fortunate to secure funding for a clinical trial to definitively answer this question, hopefully. And we are looking to start this clinical trial in August of 2021. The R61, R33 mechanism provides 1 year of funding to get the trial initiated, 12 months. You have 12 months from the funding date to enroll and randomize your first patient. And if you can do that successfully, then that triggers the next 4 years of clinical trial funding through the R33 mechanism. And so at the current time, we're working steadily to try to make sure all the administrative requirements are met and that we've hired the appropriate number of people. We're partnering with Kaiser Permanente in Northern California, and there are 21 medical centers in Northern California to help us identify and enroll patients through the Kaiser Permanente system. And we're also partnering with the U.S. Department of Veterans Affairs, Palo Alto, VA Palo Alto healthcare system, as well as Stanford Healthcare to enroll patients. So even though we're working at 3 different sites, it's considered a single site trial by NIH for this particular funding mechanism. And that means all trial activities, beginning with recruitment and consent, are going to be conducted at Stanford, but we're going to use the EMR or electric EHR at these different health systems to identify patients and then contact them about their interest in participating in the trial. We've been fortunate to be funded over a course of several years by the Heart, Lung, and Blood Institute for the research, which provided the basis for this successful application, as well as research contracts with a number of pharmaceutical companies also interested in this area. So again, I want to thank everyone for joining us this morning for our grand rounds. And we're really excited about the initiation of this clinical trial. If you see patients who have a diagnosis of abdominal aortic aneurysm disease who are not diabetic, feel free to discuss with them their potential interest in participating in this clinical trial. It's a simple randomization of metformin. It'll have a dose escalating protocol, so it's up to 2,000 milligrams a day versus placebo. Metformin in non-diabetic patients does not cause hypoglycemia, except in very unusual cases of advanced liver disease. There are some contraindications, such as stage 3 or stage 4 chronic renal insufficiency and some other situations. But by and large, non-diabetic patients tolerate metformin generally well, and we're using a dose escalating protocol to try to limit the GI side effects that can be associated with metformin. And then once they're off and running, it's just every 6-month follow-up for laboratory evaluation and a baseline and a 2-year CT scan to look at aortic aneurysm diameter. And I would be remiss if I didn't note that aneurysm management, as well as vascular care in general, is a team sport. And we're very thankful for my partners in Stanford Vascular Surgery, both our trainees and faculty, that have really made us worldwide leaders in the care and management of patients with abdominal aortic aneurysm disease, and have helped us reach the point where we may be able to identify the first effective therapy at preventing progression of this life-threatening condition. Thank you very much for your attention.